Same. Tray is going to be the same. Doing the prep and drape is going to be the same. So we're going to kind of skip all that. This is the drape I like and I was talking about. I'm just going to kind of show you. I will unfold this the one direction like that. I will take that strip all the way off, and then I'll stick my hand on the sticky part, and then once that's stuck there, you can pull it apart without it falling off yet. And then you can reach around, grab it like that, and stick it on. That's what I was talking about earlier. Okay, setup's going to be the same, except for you don't have testos. You'll have a local anesthetic for your skin wheel. And then you'll have your bupivacaine. This is hyperbaric bupivacaine that usually almost always comes in the kit. So if you want isobaric, what do you got to use? You guys remember? Hypobaric or isobaric. Now, hypobaric would probably be saline.
Oh, sterile water.
Or sterile water, sorry, it's hypobaric. You don't use saline, but usually most people use 0.5% bupivacaine instead of 0.75, and they'll dilute it with CSF sometimes, but just 0.5% bupivacaine is isobaric. This is 0.75 with dextrose, hyperbaric, sterile water, and whatever bupivacaine is going to be hyperbaric, which you'll hardly ever see. Hypo, sorry, did I say hyper?
You're good.
Sorry. They're like, how do you expect us to keep it straight if you can't? Anyway, I'll pop this open. So you got the two open. You also have epinephrine in here if you want to do an epi wash. I know we've talked about epi washes before. Does anybody remember what that is?
Yeah, you pull it up and then squirt it out.
Yeah. Pull it up and squirt it out in the syringe, and just that little bit of epi in there is going to change your duration, causing vasoconstriction, slow your absorption, and potentially lengthen your block. Epi washes on bupivacaine, this percentage of bupivacaine is statistically, they say it doesn't change the duration of your block. But if you were doing something else in the spinal, lidocaine for instance, you could do an epi wash and increase your duration. So I'll pull up 3 cc's of local anesthetic. If you're doing Duramorph, you'll have to pull that out off the side, and sometimes the nurse will hold the vial, and you'll put the 5 cc syringe on and another needle. Oh, here's the straw syringe we were talking about. It's just, it looks like a straw instead of a needle. You'll draw that up. You may have to put it in the Duramorph, draw up a little bit. The only problem with doing it that way is it's hard to dose. 0.2 of Duramorph, you're like, that's probably close, and that's like hardly anything. Some people throw on a sterile 1 cc or TB syringe and specifically draw up their Duramorph is like 0.2, and then they might hold the syringe, the other person might stick the end of the TB syringe in there and squirt the 0.2 inside of there. So that way you're very specific. Anyway, if you add the Duramorph, I always add it before, and then I draw up my local anesthetic. Depending how many cc's I'm going to do, I'm just going to assume we're doing all 2 cc's of 7.5, which is how many milligrams? Or 0.75, yeah, but 15 milligrams. 7.5 per mil. Because the thing is if you draw up your local anesthetic and then go to draw up your Duramorph, if you don't get the right amount, now you can't like squirt it out, right? Because you've got all the local anesthetic you have, and it's mixing, you're like, I don't know how much I just squirted out. So I always either pull up my local anesthetic and then add my Duramorph with a TB syringe so it's exact, or I put the exact amount in and then draw up my local anesthetic to the total amount that I want. So we'll draw up the local anesthetic. Whatever needle you're going to use, I didn't even look to see what this one was. I can maybe look at the tip of it. It's a cutting. Is it a cutting? No, it's a pencil point. It's a pencil point, so whether it's a pen can or, I don't know, a Whitaker. Not a Whitaker. No, yeah, Whitaker. It's not a Quincy. Whatever it is. Anyway, same thing. I'm going to fill the spinous process. I'm going to inject my local anesthetic sideways, skin wheel, and then I'm going to put it in a skin wheel, or then a deeper injection, anterior cephalad, caudad, and then I'm gonna put my needle in. If you use a needle smaller than like 22 gauge, you usually wanna use, this tray has a metal introducer. You usually wanna use an introducer needle. I'll take my introducer needle, I'll fill my spinous process, I'll go right above it, I'll push in my introducer needle. Same thing, introducer needle, if it's a long 1.5 on a thin patient, you're thinking, oh, I'm just gonna push this in to put my spinal needle in, all of a sudden, you might wet tap them with this. And these introducer needles are big enough where they could get a post-oral puncture headache. So depending on the size of the patient, push in the introducer needle, grab the end, don't poke yourself, put the spinal needle in through it. Now that just helps you push through. Now this, sometimes with pencil point you can feel sometimes the ligament. With a cutting needle, like a Quinky, you may not feel any changes in pressure. And so every once in a while you might just have to stop, pull your stylet out, look to see if you get CSF. If you don't, stylet back in, a little bit further, push, got a loss, or a little bit of, felt a little pop there, check it, oh, CSF's coming out. As long as you, if patients get paresthesias, right or left, that'll help you kind of guide and direct you. Want the CSF to drop out, I'm gonna grab my syringe with my local anesthetic, and again, if it's a slip tip, whatever he called that grip, Ramage or whatever, make sure it's tight, put that tip on. You're gonna aspirate, you should get Baratage, or the swirling effect in there. If it's the 0.75 of bupivacaine with the dextrose, it'll do the barrage. And then you're gonna just slowly inject maybe 1 or 2 cc's, and then you're gonna pull back, make sure you still get the barrage, and then you're just gonna kind of finish it off, inject it all. This isn't letting me, so I'm just gonna pretend we inject it. At the very end, after I'm done, I'll pull it back, I still get CSF, push it back in, pull everything out. This will set up within 5 minutes, so depending on the voricity, the surgical procedure, what position they're gonna be in, what you wanna go numb, you either can, if you're gonna do a saddle block, you'll leave them sitting, let it sink down, cover the sacral area. If you're doing a certain hip, you may wanna lay them down, roll them lateral, depending on which hip you're doing. You put the surgical hip down and let them sit there for 5 minutes while you're putting all their blood, well, you'll have it all on already, but while you're doing whatever, getting ready for whatever, or charting a little bit, and then you can put them into the position where their surgical hip's up, because the voricity is set in and got numb areas you want. So positioning, again, when you're doing spinal and voricity, it's gonna be everything when you're trying to figure out what you're trying to numb. Okay.
What's the point of, after injecting all of the medication, and what's the point of aspirating again?
So you would just wanna make sure that you're still in the spinal space. If for some reason you didn't use your full amount of local anesthetic, and you pulled back and you're like, oh, I'm not getting CSF anymore, you could potentially come back, drop a little more, redirect your needle, and at least get more if you were concerned you didn't get enough medication.
That makes sense.
Okay, so one thing we haven't talked about really today is fluid. Tell me about fluid and doing epidural spinal.
On a preload them?
Pre or co-load?
Yes, exactly. Depending on the patient, at least preload. Sometimes if it's, you need a lot